Also. Thank you for the invitation. I'm going to update you on what's new in Hep C. I didn't put my disclosures in here, but I really didn't have to be honest, because we're not talking about specific drugs much anymore. Notice there's no new drugs. So every year I've done this for you for the last 20 years or so. We've been talking about new drugs, no new drugs today. So I'm going to talk about a few key topics: barriers to treatment for HCV that still exist, 8 weeks of therapy for compensated cirrhosis, which I'm not sure we need, but it was studied, results of retreatment trials for NS5A failures. We definitely need to know about this, and the risk of de novo and recurrent HCC after cure. This has been an issue for the last couple of years, and I think we can probably put it to rest after this meeting. Regression of fibrosis after DAA therapy is a topic we've been interested in for a few years because we'd like to stop following all these patients with advanced fibrosis and cirrhosis that have been cured. We all have patients like that. We have 250 that we've been following, and we'd like to dismiss them. And so we don't know when we can do that. The overall benefits of HCV therapy, I think this is important since the Cochrane analysis came out last year and said that DAA therapies did not change outcome with hepatitis C, which is it's confusing to us all, but it's because I think we haven't had enough time yet to see those effects that we have in a transplant population. Transplant outcomes in HCV antiviral therapy, that's important, and also because they're now giving HCV-positive organs to HCV-negative recipients in heart, lung, and liver transplant, and kidney transplants, so we'd like to know how they come out. And lastly, antiviral screening in special populations and elimination worldwide. So let's talk about barriers that still persist in the U.S. Zobair Younasi put this together, and it shows that even though we live in an enlightened state, California, that's not yet quite burned down, but it's trying to, and you can see the states where the barriers have been removed. This is largely because of Medicaid expansion. The state from which I hail, Ohio, is one of the least knowledgeables and also has one of the lowest treatment rates. So these are just looking at barriers in the Medicaid population, the percentage of Medicaid patients that actually are getting treated. And the reasons are fibrosis, sobriety, and prescribers. Some states still require only certain prescribers can treat, which is really silly in this day and age. This was a good study that looked at linkage to care. Nancy Rao presented it, but it's really AbbVie's data, and they spent a long time collecting this data. And what they did was go to Quest and LabCorp, which handle 80% of all laboratory testing in the United States. It's a remarkable number, 80%. So, and 80% presumably of all the HCV testing. So they looked at everybody that had an HCV RNA test done that was positive at Quest or LabCorp, and that was a lot of people. And they looked in 2013 and 2016, so they looked in two different time periods. So these are people with clear-cut active hepatitis C infection. They're not HCV antibody positive with a negative RNA. These are positive RNA patients. And then they looked and followed them and saw how many were referred to a specialist and then received treatment, and how many were seen by a primary care physician and then received treatment. And the results really were dismal. So many of these people are out there right now. And they actually have a map that they had at AASLD looking at all the communities in the United States, and to my chagrin, in greater San Diego County, there were a lot of people in the northern parts of the county that were HCV RNA positive that were tested, never got referred, never got treated. So they're still presumably out there. But they're more likely to get treated if they see a specialist. If they see a primary care physician, for reasons that are still unclear, very few are getting treated. So this is low-hanging fruit. These are people who have already been shown to be HCV RNA positive and should get treated. This is the Expedition 8 study. I'll just briefly talk about it. It's AbbVie's study. Bob Brown presented it, and it looked at 280 patients with compensated cirrhosis that received GP for 8 weeks, and it worked. So I wasn't quite clear why this was important because, you know, I think if somebody's got cirrhosis, I'm probably going to err on the side of treating them for 12 weeks, regardless of which drug I'm using. So it didn't have a great influence on me. It looked at all genotypes, though, not genotype 3, so they left out genotype 3. That's the most difficult genotype to treat. And it had no decompensated cirrhosis. Of course, this regimen, GP, also known as Mavyret, includes a protease inhibitor, so it's contraindicated in decompensated cirrhosis, so trials shouldn't be used in trials B and C cirrhotic. So for what it's worth, looks like 8 weeks work. This was more important. This was a study from US VAs looking at patients who had failed prior DAA therapies that included an NS5A and then retreating them with a soft valve Vox, or Vosevi, as you may also know it. It's 573 patients with DAA failure. That's a lot. And overall, it worked quite well. This is genotype 1, 2, and 3. But there was a little concern that the ones who had failed soft vel, so these are Epclusa failures, didn't look like they had as good an outcome. Now, there's a small number of patients. So it's certainly not as many as were treated with ledipasvir, sofosbuvir. That's our mainstay. Those are Harvoni failures. Or soft sim, those leftover failures. So it looks like it works great in everybody else, but these few soft vel failures, a little bit of a concern, maybe the SVR rate. Anybody treated soft vel failures out there? Anybody had a failure of a Vosevi? Okay. Bob? Yes? 2? Yeah, we've had 1. So it does happen. Were those people treated multiple times? Yeah.
One was on their 4th, the other was on their 3rd treatment.
4th? Yeah. So that was our experience as well, somebody that you've clobbered with multiple therapies, so maybe it's something about that particular patient also. They usually have cirrhosis also. Retreatment with GP, this was looking at NS5A failures that had been treated with SOF, and then retreating them with 12 weeks or 16 weeks. They either had no cirrhosis if they got 12 weeks, 16 weeks if they had compensated cirrhosis, and of course you couldn't treat any decompensated cirrhotics. And they had to receive ribavirin also if they got the 16-week arm. So the SVR rates were good, but you still had some relapsers, and ribavirin is tough. I think it's pretty hard to convince somebody to take ribavirin now. So using GP and NS5A failures, I'm not sure there's a big place for it out there. I think we have a salvage drug for people who have failed DAAs, and that's sort of what I use. I do use GP with SOF in the few GP failures that we've had. Now, this I think is more important. This is a large follow-up presentation from, Raj Reddy gave the presentation, but it's Gilead's data. And they took all the people treated with Harvoni, Epclusa, Vosevi, and Sovaldi in the earlier trials, and they followed them all in these long-term registration trials. So anybody who participated in those earlier trials, remember the FDA mandated that we put everybody in long-term follow-up registration trials for at least 3 years, and they were looking for long-term outcomes to confirm the patients didn't relapse like 2 or 3 years later. So they didn't, but they could also extract other data from that, and Gilead used it to look at how many of these people got liver cancer, because this was a big issue that Maria Rigg brought up 2.5 years ago now at the AASLD meeting, suggesting that you got recurrence of HCC if you cured these people that had cirrhosis. So it was worrisome data. So long story short, this is what the data looks like. So if you started without cirrhosis, your chance of getting liver cancer over a long period of time, this is looking at very long period of time, weeks, at least 2 years, in most of these patients, 2.5 years for many of them, virtually zero. If you started with compensated cirrhosis, the risk is less than 1% per year. So that falls below the what is cost effective for HCC screening, but I still do it, and I would recommend we still do it. If they had decompensated cirrhosis, it's about 2.5%. So those are the patients you're still really worried about. The decomps that you may have treated and taken off the list, you know, they were listed for transplant and you actually got them better. So they're really still at risk for liver cancer. This is kind of drilling down, looking at hazard ratios, and it looked like you had a higher risk if you were older, if you were a male, if you had worse liver disease, if you were genotype 3, and if your platelet count was less than 150,000, so, and your pre-treatment albumin was less than 3.5. So those are surrogate markers for more advanced liver disease. So the patients with worse liver disease are still at risk for getting liver cancer. The other ones, pretty minimal. Now, this was a landmark study that was presented looking at the risk of HCC in a large VA population. This is from Single et al. And what they did was look at untreated patients and treated patients followed over at least 2 years, and they saw really no difference in the recurrence of HCC. So this was important and it was new. So this is looking at people that started with a liver cancer that had been downstaged by TACE or treated by resection and had no evidence for cancer. Then they treated their hep C, or they didn't treat their hep C. So many of us were afraid to treat hep C in those patients for the last 2 years. So they had 2 cohorts they could follow. They were randomized between 2013 and 2017. And this is you can see overall the risk of liver cancer was really, a recurrence of liver cancer was really not different. If anything, it was lower in the treated arm, certainly not higher. This is looking at a similar group of patients. This is patients that have had HCC and looking at survival alone in those that were treated with DAAs versus those that were not, and survival was actually better in those that were treated. So this has changed our practice at Scripps. After the Maria Rigg study was presented for the first year, those patients that were listed for transplant that had had a liver, that had an HCC that had been downstaged, we didn't treat, now they're all getting treated. So, because it looks like we're reducing their risk of death by treating them. And this is actually just a modeling study that was presented, and the AASLD made slides out of this, so I'm showing it. I think it's interesting. And it's one of the questions that we're asked in the pretest: who has the highest risk of getting liver cancer, who has the lowest risk? The lowest risk is obviously those with no cirrhosis that had an SVR. The highest risk is those with cirrhosis that did not have an SVR. And in between are those two other groups. This is patients that didn't have cirrhosis that weren't treated, and these were patients that were cirrhosis that did have an SVR. So for this reason, we're still following those patients that had cirrhosis that had an SVR. We haven't dismissed those people. They still have some risk for liver cancer, and the risk model here included platelet count, albumin, AST, ALT, INR, et cetera. Now, this is looking at the effectiveness of DAA therapy in those that had prior HCCs, and then looking at which treatment they received with the prior HCC. So, this is soft ribose, so this goes back to 2014, 2013. Ladipasvir, sofosbuvir, 2D therapy, declitosphere and AASLD. So this was a Japanese study, so that's why they included declitosphere and AASLD. That was an approved and commonly used therapy. And if anything, the risk was not associated with, and they also looked at prior therapies with interferon, so they had a fair number of patients here. Let me go back one, sorry. And they basically showed that the risk factor overall survival in those with HCC and no HCC was not any different, and it didn't vary based on which therapy they received. So this is just important because it's looking at other centers outside the United States, and it basically gives us reassurance that we're not making the outcomes worse in these patients. So let me go on to fibrosis regression. So this is a topic we've been interested in for a few years. There were actually 11 abstracts that I found, most of them posters, that address this issue in one way or the other at this year's meeting. So this was a typical one. This one looked at patients that were HCV monoinfected or co-infected with HIV, and they did fibroscans on them at 6-month intervals and showed that the elasticity was reduced. So presumably fibrosis was reduced after they were cured. And this was pre and this was post. And this is in the HIV population, non-HIV population, didn't seem to matter. The overall kilopascals dropped to about 7.8 from 10.7, so pretty good. And if you were to base that data, you would say, okay, well, I don't have to screen that patient anymore, we're done. The conclusions looking at all of them were as follows, though. After 1 to 3 years, viral eradication reduced liver stiffness in the majority of patients. 3 of the abstracts showed that. Non-invasive markers of fibrosis and TE are both improved, so a number of these looked at FIB4 and APRI, other non-invasive markers of fibrosis, and they also improved. There was an overall about 75% improvement over 2.3 years with a rate of about 14% a year. Half the patients didn't show improvement if they started with cirrhosis. So cirrhosis did still regress, but not as many, about half the patients. HIV co-infection didn't matter. Age didn't matter. Over or less than 65 didn't matter. And they did see some patients develop HCC that had a post-treatment TE of 6 or less, meaning that they weren't supposed to have any fibrosis in the liver at that point if their FibroScan was less than 6, but they still got liver cancer. So that's worrisome. So this is a topic we've been interested in for a few years, and Jason Pan from our group finally published this in Hepatology Communications a couple of months ago. And what we found, we followed 250 patients with cirrhosis before they were treated with DAAs, and we cured them, followed them every 6 months with with FibroScan, and showed that it looked like their FibroScans would improve back to a normal level after about 5 or 6 years. This is the ones with cirrhosis was a black line, and these are the F3, F4. But we ask, well, are they really reversing their fibrosis? So how you measure fibrosis in patients with hepatitis C is a big argument among pathologists. The best way to measure it is morphometry, which is what we had Zach Goodman do for 11 of our samples. The problem with morphometry is it's not done anywhere else in the United States. It's really only done in a few specialized research centers. It's done in Paris. It's done by Zach Goodman and Inova, but there's very, very few other centers that do this. It's a research test. But you actually quantitate collagen. And we showed a significantly meaningful reduction all the way out to 0.005 reduction in collagen in these patients that were cured. However, when we looked at specific readouts of the liver biopsies in patients that had reduced their FibroScan, so this is a patient for this group of patients started with cirrhosis. Their follow-up FibroScan suggested that only a small group had F3, F4, the rest were all below that. The actual liver biopsies did not show that. They showed they still had F3 or higher. And the same goes for the F3, F4. So this means that if we were actually biopsying all these patients we're doing TEs on, even though their collagen's reduced, there is still the evidence for cirrhosis on their biopsy, which makes us believe that you cannot dismiss them from HCC screening. So I don't think there's any time that we can do that, at least yet. If you look at the Hep B population, and Bob, I hope I'm not stealing one of your topics, but I just picked this up as an example. This was a large study done in Athens in hepatitis B patients treated with entecavir. So you know Athens and Greece has a very high rate of E antigen negative hepatitis B. Stefan Hatzianis was always the first author on all the E antigen negative studies for hepatitis B because Greece has such a high prevalence of this. They called this the Page B cohort. So they followed almost 2,000 patients for a long period of time on entecavir, 5 to 13 years. And they've diagnosed liver cancer in about 2% of them. So they looked at who got liver cancer, and they found that reversion of elastography in cirrhotics at 5 years did not appear to decrease the HCC risk. Platelets were not useful in predicting HCC risk, and they said everybody should still be screened. So they were not happy that they could dismiss reversal of elasticity in Hep B patients either, so for what that's worth. Now let me go on and talk about benefits of SVR overall survival. Despite the Cochrane analysis, we are now seeing that in cirrhotics, SVR confers an increased survival in these patients. These are SVR with no cirrhosis. This is SVR with cirrhosis. This is no SVR with cirrhosis. And these are the adjusted hazard ratios, and you can see that SVR reduces the risk of mortality greatly in these patients, so no question about that. Now, when you drill down and look specifically at what they died from, it wasn't always cirrhosis. So diabetes-related complications, end-stage liver disease, end-stage kidney disease-related complications, stroke, ischemic heart disease, maybe a little bit, mood and anxiety disorders, we know that, and on rheumatoid arthritis, really no difference. So I think they threw that in there just to show you that rheumatoid, that these other measures are valid. But I tell this to patients when I have an older patient that's, you know, I've got a few of these patients in their 80s that say, well, look, I've had Hep C for 50 years. Why are you going to bother to give me a pill for this, and the reason, and this gives you some reason to do it. I mean, I say, well, look, you're not going to die I agree, you're not going to die from cirrhosis or liver cancer, but I don't think you want to die from stroke or cardiovascular disease. So this will actually reduce that risk. It's pretty compelling. This was from another group, but it basically just looks at diabetes and cardiovascular disease and shows the same thing. So, and it looked at both adjusted and unadjusted risk, and there is a significant difference. So this is impactful for payers also in those states that still put up the barricade for fibrosis. They shouldn't, because you're reducing cardiovascular deaths in these patients. Now, this seems logical to all of those of you that are not at a transplant center, but at transplant centers it's important, and this just looks back at the era where we were treating hep C with interferon and looking at graft failure and patient survival post-liver transplant. And graft failure was higher, as all of you transplanters know, and survival was worse in these patients that had hep C. And this is looking after 2014 in the DAA era, and now their survival's the same or better than other patients. So this has really fixed this problem, and all of you know that we basically don't transplant patients for decompensated hepatitis C anymore. It's pretty much disappeared. I don't know, John, are you guys transplanting anybody like that at USC? We get maybe one a year. Yeah. From the county, right. So the patients that didn't get treated before, right. Now, what about taking HCV positive donors and giving them to HCV negative recipients? So this is a big deal for transplant centers like heart transplant centers, because the wait for a heart transplant is so long. This is the standard wait times. This was done at Mass General Hospital. 25, they looked at their standard wait time for heart transplant, and then they took 25 patients and gave them HCV positive hearts from donors, because there were a lot of donors that were being discarded. And they monitored them very carefully and, of course, treated them immediately post transplant. Actually, they gave them their first dose of GP. I believe they used GP in this study. They gave them their first dose when they were being rolled to the operating room for the heart transplant. So they started on therapy before the graft was actually put in. And so far, the study's not done, but so far everybody's had an SVR, SVR 12 and 12 of them, SVR 4 and 5 of them, others undetectable. Vanderbilt, I didn't show that data, but Vanderbilt had a similar study where they did in heart transplants, and they've got pretty much the same results. Now, on the other hand, this study was done by Jordan Feld's group at Toronto, and they did lung transplants. So they looked at, there's also a long wait, I guess, for lung transplants. So they took the HCV positive donor. They did ex vivo lung perfusion for 6 hours to reduce the viral load. So they dialyzed out the viremia, which you can do. And by the way, that was actually a goal of therapy to do plasmapheresis in HCV-infected patients about 20 years ago, because it does actually lower the titer by about a log. Not a lot, but some. And then they gave them to HCV-negative recipients in a study. So far they've only finished 8, and they were all treated with soft valve for 12 weeks. Median, they started 21 days post-liver transplant. So there was a problem there. They had to wait, and he said that was because of how sick the people were and how complicated they were in the ICU with multiple medications, et cetera. So he implied that they had to wait 3 weeks. That wasn't a great thing. But they had 2 out of 8 relapse, and one of these developed fibrosing cholestatic hepatitis, which is a dreadful complication. So he used caution and said, well, you need to think about this before you do it. Don't do this at home yet. Not ready to do that. So last couple abstracts. This was also a question on that I put on the pre-test, which is PWIDs, people who inject drugs, that's what PWID stands for, who have imperfect medication adherence. So the argument was that they're not going to stay on their meds, they're flaky, they're not reliable, you're not going to give them expensive medicine, so they're going to have poor outcomes. And so what they did, this group just basically looked at a group of patients like that and showed that the medication adherence didn't have any effect on SVRs. And they measured viral load at week 4, which is a surrogate marker for adherence. So if your patient's not taking drug, their viral load's not going to be suppressed at week 4, and you know right away something's wrong. But they then looked at who finished late or who finished early. So they assumed if they finished late or early, they missed some pills or they weren't completely adherent. And their SVR rates were 95% across the board. So it really didn't matter. Now, what about patients that use injecting drugs or that are injecting drugs getting reinfected? So that's the other big argument from these states that put up barriers and say, well, we're not going to pay for drugs for these patients because they're just going to get reinfected with Hep C anyway. So remember, John Ward from the CDC says that the real reason to treat PWIDs is because of herd immunity, basically, in effect. Basically, he says if you can eradicate the infection in 30% of IV drug users, they stop transmitting across the population. And that's all they have to do. So the real reason to treat them is to stop the Hep C from being transmitted to other IV drug users. So what this was done by Merck. This was their SCSG COSTAR study. They did this study a number of years ago, but they followed patients now for a number of years and shown that there have been 10 reinfections among all persons, and 6 of those were related to injection drug use. I guess some of those were sexual exposure. So they were actually able to put a number on this and say, well, the rate of reinfection is slightly higher in injection drug users, but it's still only 2.8 reinfections per 100 person years, so it's relatively small. Now, what about screening pregnant women? So remember, we screen pregnant women for hepatitis B. We don't screen pregnant women for hepatitis C. There have been a couple studies, and there were a few studies at this meeting, I didn't put the abstracts in, showing that it would be cost effective to screen all pregnant women for hepatitis C. If you did that, and then you look at the subsequent cost of preventing an infection at delivery and also for the mother, you're treating 2 people, the mother and the child, it's cost effective. And this was a study done by Rose et al., basically looking at, that concluded universal screening with reflex HCV RNA testing. So this would be antibody screening. Interestingly, half the women with a positive antibody in many of these studies do not have active hepatitis C. So they've been exposed and they develop antibody. They're young people, they've got a robust immune system. It's not that surprising. But they basically say this would be cost effective and we should do it. So we just need a will to do it. What about treating prisoners? This has been a big discussion because John Ward from the CDC says that prisoners go into prison without Hep C and acquire it in prison, or they go in with Hep C in prison and come out with Hep C, and then they transmit with IV drug use. Prison is our way of treating IV drug use in the United States, of course. How many people touch the penal system in the United States per year? You know the answer to this, John. How many people touch? Come on, you guys know. Come on, half you guys are on probation. You know the answer to this study. 10 million. 10 million people, 4 million in prison. So it's a big number here. So what they did in Spain here was they just looked at these people and treated them by using telemedicine when they got out of prison. They saved $665. Keep in mind the drug's cheap in Spain. And they got great SVR rates. So they said, well, this is cost effective and we should be doing it. So basically, where there's a will to eliminate Hep C, it is possible. And this data has come from Egypt. Egypt, interestingly, has led the way because their Minister of Health is very motivated to eradicate Hep C. I've seen her at the HepDART meetings over the many years. I've seen her in meetings overseas, and she comes to AASLD and EASL. She's very, very motivated to do this, and she has convinced the Egyptian government to screen. You know how high the prevalence of Hep C is in Egypt, and they've actually done a very good job here. They screened and RNA tested 100% of patients, which we don't do at all. They found 51% were RNA positive. Then of those, they treated 86%. So those numbers dwarf anything that we do in the United States or the Western world. But so they have a will to eradicate Hep C. There is a WHO mandate to try to reduce Hep C worldwide down by 80% of its current levels. So I think this will be possible in Egypt, and they show that where there's a political will to do this, it is possible. And that's it. I'm done. Okay, half an hour. Half an hour break. We'll see you back at 10:25.